Welcome, Deborah. Thank you so much for being with us.
Hi, thank you. Thank you for having me.
I'm especially grateful that you're coming on to share both your experience and some of the clinical side of this, because I'm sure, as you know, it's not talked about enough. And uh, you know, you coming on to share your experience and give tips and pointers or perspective to care providers is incredibly important. But also, you know all this already, but I'm just going to overstate it for folks who are listening. Unless you hear this from somebody else, unless you hear somebody's story, it's really hard to figure out that you can advocate for yourself or share your own story. So this is really, really important. So thank you for coming on.
Yeah, absolutely.
So I will just let you start wherever you feel comfortable with your own story, and yeah, how your trauma impacted your experience.
Yeah. I like to say my story began from the moment I saw the positive pregnancy test. But certainly prior to that, I always knew I was a survivor. And, the moment I saw that positive pregnancy test, I remember feeling this really intense feeling of anxiety to the extent that I had to lay on my stomach just to help tolerate some of that. So I remember feeling this really deep, sinking feeling. And, this was very much a wanted pregnancy. So the whole sensation was very bizarre to me. Um, Physically speaking, my pregnancy was, quite easy. I think some pregnant folks may hate me for this, but I didn't experience any morning sickness. Like I was feeling physically great.
Mm-hmm.
Emotionally speaking, though, I was really a hot mess.
Mm-hmm.
I remember just experiencing severe depression and anxiety. And throughout this whole time, I had seen a therapist, I was seeing a therapist, and she never once mentioned to me, like, hey, this could be perinatal anxiety and depression, certainly, being exacerbated as a result of your trauma.
This is somebody who knew your history already or who you began seeing during pregnancy.
No, this is somebody who knew my history already.
Got it, got it. Mhm.
Yeah, yeah. And, I recall feeling like there was a parasite inside my body.
Mm,
So almost like this idea, like just get it out of me. Like I was
yeah,
just so eager to get this child out of me.
yeah.
And as I reflect back, I look at my pictures, during that time period, and I actually don't have even one picture of me being pregnant.
Mm.
I was in complete denial. I remember saying to my husband, I don't look pregnant, right? Like I kept saying that to him. And I wore like extra large clothes just to hide the pregnancy and just to look like I was fat versus pregnant. Um, I remember being just in complete and total denial.
Mhm.
The scariest thing happened to me when I was 35 weeks pregnant. I went in for a regular routine, checkup with my OB, and she had taken me into the room and said to me, honey, you're 5 centimeters dilated and your contractions are 3 to 5 minutes apart. You're in active labor.
Sorry, how far along were you again?
35 weeks.
Oh, okay.
So I was 5 centimeters dilated and my contractions were 3 to 5 minutes apart.
Mm,
Um, and my husband, again, this was a 35-week visit, so he didn't come with me to that appointment. And this was prior to COVID.
right.
And I remember calling him at work and saying, they say I'm in active labor. And the doctor said to me, she said, you're not feeling anything? And I said, no, I'm not feeling anything.
Mm.
She said, I think you're magical. Like, what's wrong with you that you're not feeling anything? And I was like, I don't know. So we packed our bags and we went to the hospital. And the hospital was about an hour drive from my house at the time. And I remember just being terrified that there was going to be a baby in this car. Because
Mm.
again, I wasn't feeling anything. So I had no way to gauge myself of like
Mhm.
what was happening.
Mhm.
So I got to the hospital, and I was there for a little bit being monitored. And, at the end of the day, so then what happened was that my contractions stopped,
Mhm.
but I was still dilated. So they sent me home. And I, again, for, the next couple of days, I was just not sleeping. I wasn't eating. I was terrified. It was so scary to me that I wasn't
Yeah.
feeling anything. And like, how would I know from having this baby?
Right. Exactly. Yeah.
And I went in again for a couple other visits, and they gave me a I believe it was a steroid vaccine
Mhm.
to help, um, to really ensure that the baby would be healthy, should he come early. Um, and then at 37 weeks, I went back into the doctor's office, and sure enough, I was in active labor again.
Mm.
And 5 hours later, I delivered my son.
Mm. Wow.
And
This is also totally unexpected. You're going in for not unexpected, given what you were going through, but there was for you and still not a feeling or a sense of that what was going on.
no sensation. It
Mm.
was absolutely terrifying.
Mhm.
And, throughout the entire labor, like I didn't feel any pain. Now, granted, I did take an epidural in fear of feeling pain.
Mhm.
So at that point, I didn't feel anything. But um, prior to that, I really did not feel any sort of sensation. And I remember, like the second after I gave birth, I burst out crying. There
Mhm.
was this sudden sense of like an overwhelming amount of responsibility.
Mhm.
And I remember the nurse turned to me and she said to me, "Are you okay?" And I was like, "Yeah, of course." And, of course I wasn't okay. And that entire experience, was so frightening. And I truly
Yeah.
believe that I was completely disassociated
Mm.
from that, which is really why I didn't feel any pain.
Mhm. Mhm.
Um, and postpartum for me was incredibly challenging. All of my symptoms of, perinatal anxiety, depression exacerbated. And on top of that, I developed significant OCD,
Mm.
especially intrusive and really, really frightening thoughts.
Yeah.
I engaged in a lot of avoidance, and just really, really terrified and scared.
Mhm.
Um, and that pretty much sums up my story in a very, very brief journey. I'm
Mhm.
sorry, in a really brief nutshell.
Mhm. Mhm.
And so much of what I'll be talking about, in terms of survivors and their experiences,
Mhm.
all relates to my story. And it really wasn't until I had gone for my training from the authors of When Survivors Give Birth
Mhm.
that I suddenly realized, like, wait a minute, they're telling my story.
Mm.
And, at that time, like I said, I was seeing a therapist. And I said to my therapist, at the time, I said, I just want to hand you all these resources
Mm.
because I am so upset that I was never told that, like, this is, expected, right? That, like, this is postpartum and perinatal anxiety and depression. Like,
Mhm.
you
Mhm.
don't have to feel this way.
Right.
And I provided her like with a whole lot of resources about PSI, about birth trauma,
Mhm.
about, all the really important things that I would hope that all survivors and all birthing people, would have access to.
Right. Right. Yeah. It is, it sounds like almost all parts of your journey were um, new and surprising in some way. Like how do you not feel this? And maybe during pregnancy too, what is that feeling about feeling like there's a parasite and just needing to, get this baby out? Because all of the sort of like quote unquote fairy tale storybooks say that of course you're supposed to love all of this and uh, pregnancy through birth and postpartum and whatnot. So, was this also the first time you were kind of learning that it could feel terrible?
Oh yeah. Yeah. This
Mm-hmm.
was my first pregnancy. It absolutely, absolutely.
Mm-hmm. That is a whole lot.
So, it's important to recognize that the World Health Organization, states that about 1 in 3 women will experience physical and or sexual violence in their lifetime, right?
Mhm.
So those numbers are really high. Um, and it's important to recognize the impact, that happens to them during the reproductive years.
Mhm.
So certainly when we talk about pregnancy, many survivors are going to feel a lot of shame
Mm.
related to their body,
Mhm.
specifically about their bellies growing, their breasts growing. They feel a lot of disgust and shame. So
Mhm.
sexual shame and disgust
Mhm.
oftentimes coexist.
Mhm.
They're oftentimes going to have a lot of fear around having any sort of pelvic or vaginal exam. They will oftentimes be fearful of seeing the baby inside their body.
Like
Of
via ultrasound type,
correct.
any kind of imaging.
Yes,
Mhm.
ultrasounds, exactly. Yes. Many of them are terrified and are completely out of touch, with their body, right? Kind of
Mhm.
similarly to like what I was.
Mhm.
And they may view themselves as defective and very sensitive to touch, and whether that be sexual touch or physical touch.
Mhm.
They may be very codependent, on any sort of medical staff or their partners. They may have a really, really difficult time trusting their providers,
Mhm.
and they may prefer, one gender over the other. Right. So sometimes I'll hear, people say, oh, this client is just so complicated, right? Like they're just being like they're such a difficult patient.
Mm. Mhm.
And really, they're not trying to be difficult. They're just trying to get their needs met.
Mhm.
Um,
Yeah, can you if I can go back for just a second, can you say a little bit more about that, like the codependency, I guess, on the partner provider? Like what would that look like?
okay, so they may be very dependent,
Mm.
rather,
Mhm.
on the caregiver and the medical staff. So very
Mm.
dependent in terms of
Mhm.
like not wanting them to leave the room, very
Oh,
much
right.
like wanting them to be with them the entire time, not wanting to be left alone.
Yeah, yeah.
They may be asking a whole lot of questions,
Mhm.
very, very fragile, very concerned and very scared, very frightened.
Yeah. I imagine, what you were describing, that kind of feeling dependent on on maybe a partner or some part of the medical staff, and then also at the same time not knowing who to trust, how conflictual that can feel and overwhelming that can feel. That to need both,
Yes.
to like need the support, but also not know who you can trust.
Yes. Yes. Absolutely.
Really difficult. Okay, yeah. Thank you for going into that.
Yeah. The other thing that can oftentimes be very concerning, and this is really a whole other separate issue, is the gender of the fetus or the baby.
Mm,
For example, if the survivor perpetrator was male, the idea of having a penis inside of them
mm-hmm.
is absolutely terrifying.
Mm-hmm.
And again, just a whole lot of fears around the birth and the entire labor process and being restricted to a bed. All of
Mm-hmm.
that brings up so many concerns.
Yeah,
Um,
absolutely.
yeah, and being undressed, during labor, right? Being on
Mm-hmm.
display.
Mm-hmm.
So thinking about too, oftentimes in different hospitals, they will have like residents, and if it's a teaching hospital, they'll have students want to
Yep.
come in, and that can be so frightening and concerning.
Right. So, like, feeling already super vulnerable and then not knowing who's going to be in the room, or, yeah. If somebody you don't know, or somebody who's not part of your care team is coming into the room, how much more vulnerable they might be feeling.
Yeah,
But yeah, for
absolutely.
sure. For sure.
The other thing too, and I think this is like an interesting point that we don't always recognize, is the bodily secretions can be very triggering for them. So
Mm-hmm.
things like seeing blood, amniotic fluid,
Mm-hmm.
and many of them are hyper concerned about actually pooping during labor.
Mm-hmm.
I'll never forget where a survivor told me that after she gave birth, the first question she asked the doctor isn't, is my baby, okay? It was, did I poop? Right. A
Mm-hmm.
lot of fear around, shame about pooping in
Mm-hmm.
labor.
Right. So I guess I'm hearing then, um, too, that the deepest, sort of most intense feelings are shame,
Yes.
shame and or embarrassment, vulnerability, just I mean that juxtaposition of feeling those feelings and then being super vulnerable at the same time, like labor and having all these people in the room is a lot to manage
Yes.
emotionally.
Yes. And not only shame, but also like feelings of out of control, right? Like I
Mm,
don't have
mhm, mhm,
autonomy,
mhm,
and I'm just completely out of control.
mhm.
Yeah, absolutely. The other thing too is, certain body positions that oftentimes, medical staff, whether it be doulas or physicians, will ask them, to kind of go into certain positions, whether that be putting their legs up, their feet up on the stirrups, or, going on all fours to help with some of the pain, can also be very, very triggering.
Absolutely.
Um, Holding the baby, can also be very terrifying to them. The hospital environment. So if somebody, had to have any sort of forensic exam post assault, post
Oh,
abuse,
oh, uh-huh, uh-huh.
so now being in a hospital, right? Even if it's to have a baby versus the forensic exam can be very triggering. So the smells, what they're
Mhm,
seeing,
mhm,
what they're hearing,
mhm.
all of that.
So, right, all like all sensory stuff is really heightened. You were saying
Yes.
about touch before, like maybe even during pregnancy and anytime. Touch and smells and sounds and all of that stuff could just be like on volume 20.
Yes, exactly.
Hmm.
Exactly.
Hmm.
Very hyper aware. Absolutely.
Right. Which in and of itself is really a lot. Like if you're on alert, sort of like looking around and feeling around for what's safe or what's even happening. Like not even if it's safe or not, but what actually is happening. Like, why is this nurse giving me this thing? Um, that's incredibly overwhelming
It
just to
is.
manage that. Let alone, all the other layers that you're describing.
Yeah, absolutely. And the other part of that too is that there's really a power differential there
Hmm.
where, if the survivor is oftentimes, not as knowledgeable as the medical staff. So they're
Right.
talking and they're doing all these things. They're able to walk around freely versus the survivor is in bed, right?
Hmm. Hmm.
They're the recipient of all those different interventions. So that too is something to be mindful of.
Yeah. Yeah. Absolutely.
Yeah.
I know you're gonna talk a little bit more in a moment about how how providers can be aware of this, and in hearing all of the things that you're describing that somebody can feel, who has gone through the experience and who's going into pregnancy or birth, and postpartum. It sounds like it could feel really hard to feel empowered in these dynamics if you're feeling that vulnerable. Um, yeah. So anyways, I know you're going to give some perspective on what providers can do and maybe also on what survivors can do, but it's just um, striking in a way of how many different things could be happening in somebody's experience. I'm not saying that all of it is happening all at the same time, but there's just so many layers here.
Yes, There really is. And I think that's really what's not being recognized by the outside world. How
Got
many
it. Got it.
layers and
Uh-huh.
how triggering it really can be.
Yeah.
Um, and the other thing too to be thinking about is like any medical instruments that are going to be used,
Mhm.
right? So, things like, forceps or a
Mhm.
vacuum, giving the patient stitches, um, you know, a patient who has an episiotomy, right? Like all of these things can be so activating for the survivor. The sensations during labor, not just the physical sensations, but also hearing themselves yelling and
Mm.
pushing and
Mhm.
screaming, all of
Mhm.
that too can be so triggering for them.
Right. Well, I wonder too, because you were saying before, in like your own personal experience, there was like a dissociation or disconnection,
Mm-hmm.
from what was going on. And there's a lot of reasons that people do dissociate, mostly coping and protection. But this, when you were just describing that feeling of overwhelm and having so many things going on, it made me think that the providers in the room might not be aware that all of that's going on. Like somebody could be having a really internal experience and be like seemingly like quote unquote handling it fine, but maybe they're actually just trying to get through
Mm-hmm.
and being very quiet. Yeah. So, right, providers might not even notice or know that somebody's going through something if they're having to be quiet in order to cope.
Yeah. And that's something that I'll oftentimes educate, nurses on or things like that. I'll talk to them about the passive patient, right? The
Mhm,
patient
mhm.
that's like the really good patient,
Oh, yeah, yeah.
because they're just kind of complying and listening. And it's really because they feel defeated
Mm,
and more importantly, shut down
mm,
and
mhm.
unable to use their voice.
Right.
So yeah, that's a really important point. And I'll talk about this a little bit more in a bit, but thinking too about, breast or chest feeding and how activating that can be.
Mhm,
And things around, changing the infant's pamper, right? Looking at the genitalia, feeling the genitalia when they have to change a pamper or bathe them. Being left alone with the baby.
mhm.
And certainly, sexual intrusive thoughts can very oftentimes occur.
Right.
Um, and the other thing too to be thinking about is a recent very large study confirmed that 1 in 12 survivors meet the diagnostic criteria. So I'm sorry, 1 in 12 pregnant survivors meet the diagnostic criteria for PTSD.
Mhm, mhm.
And a study from 2021 confirmed that women with sexual abuse history report more obstetrical complications, unplanned C-sections, and are 2 times more likely to hire premature infants than women with no sexual abuse history.
Mhm.
And I think this very much relates to my story. Although in the end I gave birth at 37 weeks, which is, full term, um, I could have been, dilated for I don't even know how many weeks. It was only at
Oh,
35
right.
did they actually, see that for the first time. But
Mhm,
I truly believe that the reason why I went into preterm labor is because I was so anxious
mhm,
as a
mm,
result of being a survivor.
mhm, mhm.
So certainly, providers being very aware of that, um, and thinking about how they best want to support clients and or patients, in that time period.
Right. Um, this just is not, and maybe providers, OBs, nurses, or whoever's in the birthing room may or may not have had any of this training, and most likely not had any training on how to recognize this, or a couple of hours here or there. But it's with all that's going on in the room, birthing and whatnot, attending to mom, attending to the pregnant person or the baby. if this isn't something that is just, that they've had some deep training on, it might not be in their awareness.
Hmm. Yeah.
Which, yeah. Yeah, I mean, there's all of the stuff you're describing with all the potential complications or difficulties within pregnancy and birth. It You had said before, the patient or client or whoever the birthing person could seem like a difficult, like you said, or they could be really passive and the perfect patient. And are there any other ways that people might be sort of showing up emotionally there, other than feeling like they need to be the perfect patient or being more vocal?
I think the third option would probably be one person, a person rather who is just completely like flat affect, completely shut out completely, right? So not being like
Uh-huh.
necessarily the passive or the perfect patient, but
Okay.
rather just completely disassociated and separated from the experience. Probably what I must have looked like as a patient in that room.
Okay. Like not affected and
Like,
not
yeah,
interacting or
almost, I'll never forget, like, the first thing I said to my husband. So after I cried, I said to my husband the first thing before I even saw my baby, right? Like, or anything. I said to him, grab me, like, can you give me my phone? I just want to tell everybody, right? Like, it was almost
uh-huh.
bizarre to me how,
Oh,
like,
okay. Right, right.
that was my hyper focus. Like, I had no idea whether my baby was alive,
Mm-hmm,
technically,
mm-hmm,
right?
mm-hmm.
I mean, I'm sure somebody would have told me, but, I really was completely, like, that was not my focus. Like, I was
Mm-hmm,
so disassociated, that, like,
mm-hmm,
just so detached from
mm-hmm,
reality. And I think really that is what we see as well, like a complete detachment from reality.
mm-hmm, mm-hmm. Um, like no, I'm not saying you specifically, but like the person who's experiencing this is there, but they're not attending to details of
Correct.
like what's happening in the room. Like that sounds like your experience was more like just like taking care of business.
Yeah, business as usual. And
Okay.
I will always tell my I will always tell my support group members, how, one of the things I talk about in my support groups is, career versus parenthood, like
Mm,
that huge shift in identity.
mm-hmm,
And
mm-hmm.
I remember being in labor. Now, granted, I didn't feel anything, but I was in labor having a phone interview and just
Mm,
that complete detachment
mm-hmm.
of, like, and why didn't anybody see that as bizarre, right? Like, why was nobody like, honey,
Oh,
what's wrong
okay.
with you? What's
Yeah, yeah,
happening? Like,
yeah.
what? So I think that in and of itself was very, very frightening, for me now to recognize, like, that wasn't okay. But
Mm,
it also makes me wonder, sort of what you said earlier, of like, how can providers have a better understanding of, when you see a patient like that, how to
mm-hmm,
best intervene, and how
mm-hmm,
to recognize the signs of, like, something's going on here, right? This person is clearly in a traumatic response.
mm-hmm, mm-hmm. Yeah. Um, yeah, absolutely. And oh gosh, there's just so many different ways that they could respond, that they meaning the providers could respond to that. Um,
Yeah.
some of which I'm sure are supportive and some which are not. Ah, it's really difficult in big medical systems with huge teams of people to have everybody be on like on the same on board on the same wavelength, like noticing and recognizing and supporting somebody who's going through this. And I think I do hear that you're going to tell us there are ways that they can. So that's nice.
Yeah, and I think that's really where the focus is. Like, even if you have no knowledge or understanding of how to support survivors,
Hmm.
there's number one things that you shouldn't do, but then there are always things that you should be doing,
Yeah.
regardless of whether
Right.
the person's a survivor,
Yep.
right? And and in the research that I read, and a lot of the research is, very qualitative in nature and very narrative, because I
Mm-hmm.
think that's
Mm-hmm.
that's kind of the nature of this,
Yeah.
which is really impactful. Even though there may only be like 3 or 4 participants, I think the stories speak to the community, and more often than not, in these survivors' stories, they're sharing about these are the things that were really harmful that my, providers did or
Mm,
said,
mhm,
right?
mhm.
And they're talking about ways in which they could have just showed up. And it's not anything
Right.
like, oh my goodness, they had to come and do EMDR. It
Mhm,
wasn't anything intense like that. It was, if only they would have asked me permission before they did this,
mm.
or if only they would have respected me and my privacy, all these different things that I'll get to in just a minute, ways in which they could show up, to
Right.
anybody, but even
Yeah,
more
oh, yeah,
survivor.
absolutely.
Yeah. So shifting gears a little bit, I want to talk briefly about how therapists, and then I'll talk about how medical professionals can intervene, but
Yeah,
more importantly, therapists, as I am a therapist.
right.
And, first and foremost is obviously the therapeutic alliance, right? The therapeutic
Mhm,
relationship.
mhm.
The therapist and the client are egalitarian, right? Like they're equals, where this is a very, there's no one inferior to the other, right?
Yes, ideally, yes.
Um, yes, yes. So moving on from that, once there's trust, once there's rapport, walking clients through a list of potential triggers is really important. So, what I mean by that
Mm,
is, first of all, having the client recognize when they feel activated in their bodies, right? So, Bessel van der Kolk talks a lot about trauma in the body.
mhm.
And oftentimes he describes that, survivors of abuse have absolutely no idea, how to feel inside their bodies.
Right, right.
And having clients come up with the adjectives or some words around how they know they're feeling calm, right? So they'd be starting first with physical things like, how do you know when you're hungry, or how do
Mhm,
you know
mhm,
when you're
mhm.
tired, and then moving into how do you notice when you're calm in your body. And then as you walk through the list of triggers, so if you're meeting somebody prior to conception, then walking through potential triggers that can come up um, in pregnancy. And then if you're meeting somebody in pregnancy, talking about a list of potential triggers that can happen in labor and delivery and then postpartum. And all of this can be accessed through, Penny Simkin and Phyllis Claus's book, When Survivors Give Birth.
Mhm, mhm.
Um,
Yeah, they're
and
on my, like, wish list of people to interview.
they're phenomenal human
Uh-huh,
beings. Oh my
uh-huh.
goodness. And they really really talk about this in great detail in their book, and also in a lot of their articles. And having clients notice in their bodies, are you feeling activated, or are you feeling cued when I say this, and having them identify what potentially is coming up for them, and then coming up with possible solutions
Mm,
together,
mhm, mhm.
right? So it's not necessarily going to be about um, increasing distress tolerance. It may be about workarounds.
Mhm,
So, for
mhm.
example, if a client
I like
says,
that, yeah.
yeah, right. So if a client says like, I'm terrified to change the baby's pamper, right? So rather than, again, like I said, increasing their stress tolerance or even doing some sort of like exposure on that, rather, is there a partner? Again, this may be
Mhm,
just for
mhm,
the time
mhm.
being, but is there a partner that can change the pamper? Or can you wear
Right.
gloves when changing
Mhm,
the pamper, right?
mhm.
Like, can we come up with a solution
Yep.
to help with that?
What I specifically, love about that is that you don't have to, like, treat the trauma or have the trauma be resolved in order to have an experience that feels less triggering or that
Yes.
feels less overwhelming.
Yes.
Because I feel like, well, I know for a lot of people who have survived any kind of abuse, but in particular sexual trauma, it can feel like immovable, like it's just, can always feel like, how am I going to do these things without, while still having, that experience live within me the way it feels right now. And you're really making very clear that I love this, like, workaround idea. We don't have to go back in time right now to fix everything in order for you to have an experience that feels better for you.
Yes. Yes, exactly. And I think
Mhm.
that's oftentimes the mistake, that I was certainly guilty of prior to this knowledge, where, you know, we don't have to try to fix everything,
Mhm.
it all at the same time,
Yeah.
and I think oftentimes therapists can do that,
Mhm.
with great intention,
Sure.
but
Yep.
that's not necessarily always the best option or
Mhm.
solution for their clients.
Mhm.
Um, and obviously teaching clients about their feelings and teaching them to help tolerate their feelings, that we're not trying to change the feelings, right? And I think that's something oftentimes we try to do, is when clients will say, like, I feel so guilty, I feel like I'm to blame. And,
Mhm.
our initial response is, you're not to blame. And rather just allowing them to feel that feeling and teaching them to allow it to move, right? So I
Mhm.
always talk about, like, how can we support the movement of that feeling? We're not
It's
there to
not gonna
change
stay
it.
there forever.
Right,
No,
exactly.
or in this very moment, it's not gonna stay there forever.
Exactly, exactly.
Mhm.
And the other thing too, and I think this word will speak so much, to survivors, is telling them that you believe them. Those simple
Mhm.
words of, I believe you.
Mhm.
I remember feeling crazy. And
Mhm.
I really do. I remember sharing these things with my therapist, and she just kept putting it on anxiety, like, oh, you're feeling anxious.
Mm.
And that didn't relate to me. It
Mhm.
wasn't just anxiety, it was something more.
Yeah.
And when my therapist currently, when I shared with her my experience and her response, and she just sat there silently and compassionately taking it all in, I remember saying to her at the end of my session of, thank you for believing me.
Mhm.
And it wasn't that she said anything. It was the experience of, I'm not trying to change your narrative. I'm not trying to
Right.
question your narrative. I
Right.
believe what you're telling me.
Right.
So really, letting survivors know
Yep.
that you believe them.
Yeah.
And, as Megan Devine, who's a wonderful human being, says in her book, It's Okay to Not Be Okay,
Mhm.
never tell clients, I can't imagine what that must have been like for you.
Mhm.
Imagine it. That's how you can show compassion,
Mhm.
right?
Mhm.
Imagine it. So just some things to be thinking of, and to be mindful of. Um, we have a lot of great research around, things like circle of security and trauma-based methods like
Mhm.
somatic experiencing,
Mhm.
EMDR, and things like that, which is really wonderful. One of the things to recognize is I practice trauma-based yoga I'm sorry, trauma-sensitive yoga with a
Mhm.
lot of my clients. And the reason why that is wonderful is because everything is via invitation only.
Mhm.
And recognizing with any sort of modality that you choose to use with your clients, many of them didn't feel like they had any autonomy over their bodies during
Right.
the abuse. So recognizing and helping them, well, rather helping them understand that they have the right to say, I don't want to do this pose,
Mm.
right? Like, I invite you to do it, but by all means, like, you can take it or leave it. And that's with EMDR, that's with
Mhm.
somatic
Mhm.
experiencing, that's with really any sort of trauma-based method
Mhm.
where it's only via invitation. So thinking about that as well.
Mhm.
And just to kind of really wrap up in terms of what therapists can do, helping them too with different guided meditations and visualizations, but again, bringing them back to safety of the here and now. And I think this speaks to what you and I were talking about before, where you had asked about, like, disassociation, or when
Mm.
a
Mm.
client is completely detached from reality,
Right.
like having them come back into safety of the fact that they're not there in the abuse, right? Like,
Mhm.
they're safe, they're okay, having them notice that they're breathing, that their heart is beating,
Yeah.
really bringing them back to safety of the here and now. And then, of course, finally creating a birth plan together. I consider it more of an emotional birth plan versus a, physical birth plan, if you will. One that will include a trauma-sensitive doula,
Mm.
and really helping them recognize, like, what do you have control over versus what you don't, right? Because I think the reality is there are many parts of the birthing experience that somebody doesn't have control over, right?
Right.
So
Totally. Right.
helping them recognize what they do and what they can do with it. And like we talked about empowerment, having them recognize that, they can be their own advocates, but if they feel like they can't use their voice, then who can be their advocate in that
Yeah,
space?
for sure. That's so important. Because it's right. If you're thinking about the birth situation and environment too, especially if you haven't gone through birth before or C-section or however it is that you're birthing, there's so much going on to that, like you were describing before, that they might be taking in or trying to understand. Um, to then also have and hold an awareness of all of the things you need and the things that you wanted to do while you were it's so hard. Like, so many parts of your brain have to be involved in just experiencing something and also being aware of what your needs are, and that honestly takes a lot of practice. So right, having somebody you feel like who knows your wants and needs is so important, and that they can speak on your behalf.
Yeah.
Yeah, I love that.
Yeah. And then, finally, talking a little bit more now about how medical professionals can really provide trauma sensitive care, trauma informed care.
Yes.
So, thinking about how obviously it's always going to be whether or not the patient is okay with it, but having one medical person, being assigned to write on the patient's chart, like this is a survivor, so that the survivor then doesn't have to go tell each person, oh, by the way, I'm a survivor, so please can you ask me permission when you do this, but rather having that on their medical chart so that anybody who will come in contact with the patient will see this in big red letters and will
Yes.
hopefully provide more trauma-informed care. Um, and thinking about it too, so if a patient is being rushed into, whether it be an emergency C-section or an elective C-section or any sort of procedure that will require them to be under anesthesia, again, that's another person that the patient is having really take control over their body, right? So informing them of what's going to happen. Some clients may request a video post-surgery of what happened. A survivor once shared with me, she went in for breast surgery, and she came into me for a counseling session, and she said to me, I know this is probably going to sound crazy to you, but I really want to get a video of what happened to me during breast surgery. I just don't know why, but I feel like the doctor did something to me while I was under anesthesia. And, to somebody that may be like, that sounds like, delusional, I don't know, paranoia, right? But whereas as a survivor, I get
Right.
that, right? Like that is so, it is so scary to them to have somebody really, overtake their bodies.
Yeah, I was just thinking like that. There are so many ways that some medical systems have restrictions around videotaping and stuff like that, or recording any kind of audio or whatnot. I mean, like that, it just reminded me that there's this whole other bureaucratic layer that people might be having to navigate.
And that's probably one of the most big, that's probably one of the biggest challenges is, you're right, the bureaucratic layer that will apply to so many things that I think makes it challenging, which is why many survivors will actually opt to have, to give birth in a birthing center
Sure.
or at home or something like that because of that. So definitely. Obviously, most importantly, asking patients permission, right? Like that's what we just keep talking about. Like it's such a simple task. Asking them permission before you engage in any sort of procedure, or anything, whether it be just touching them or asking them questions. Communicate with them every step of the way, letting them know, like, I'm going to be doing this next and that next, right? Asking for feedback. I'm checking in with you. How is this feeling to you?
Yeah.
Really refrain from saying things like be still, be calm, don't move, right? All of those words can be very triggering.
Yeah, not good.
Yes, allowing the survivor to set the boundaries, again, as much as possible, right?
Mhm.
proceeding very, very slowly. Especially in the world of reproductive medicine related to like IVF.
Mm.
Many survivors have shared that they would like to insert the probe, the ultrasound probe or the speculum themselves. So
Yep.
honoring that request, right? Um, and again, just it's so important to give the patient as much autonomy as possible. Allowing them to wear something that may be against hospital policy if it's all possible, right?
Mhm.
Like teaching them, and I know this is going to sound funny, but like this is coming from actually like nursing research articles where it's telling, like it's really telling patients like try to break the rules, obviously not in a dangerous or extreme way, but wear your favorite PJs, bring your
Mhm.
favorite blanket,
Right.
wear your undergarments if it's what makes you feel most comfortable during labor and delivery. Bring in your favorite smelling essential oil, like really coming in with making it as much as comfortable and as sensitive as possible.
Right.
It's important to not rush contact between the birthing person and their baby. So,
Mm.
many times in labor and delivery, again, like the survivor is in a traumatic,
Yep.
they're having a traumatic response, right? So then suddenly them giving this baby is like, oh my goodness, right? So they may also be terrified to hold the baby or to look at the baby. Um, Ensuring that they have resources, right? I know that's always a challenge. So doing doing the work beforehand. Of course, respecting their choices, avoiding any sort of exposure, right? Um, Following their lead. Also, they may have no idea how to care for a baby. So teaching
Right.
them how to hold the baby, how to follow the baby's cues.
Mhm. Mhm.
And, so coming back to this idea of like finding workarounds,
Yeah.
one of the most activating, triggering time for a survivor can sometimes be breast or chest feeding.
Mhm.
So thinking about, can they use a nipple shield, or if they want to, exclusively pump or formula feed. Again, not touching them, right, when trying to show them how to breast or
Oh
chest
my
feed.
gosh. I've heard of such horrible. Yeah. Yes.
Yes.
Some great stories and some really difficult ones. Yes.
Yes, right. So just being so mindful of that,
Mhm.
and it's interesting because the research on the one hand talks about breast or chest feeding as being a wonderful time for survivors. But, I recall being repulsed by it. It was
Mhm.
intolerable. And I
Mhm.
remember completely disassociating every time
Mhm.
my baby would latch.
Mhm.
So recognizing that it's really not one size fits all.
Yep.
Um, Again, reminding the survivor about self-compassion and taking care of themselves and setting boundaries with others, and of course autonomy. Teaching them about breathing exercises and mindfulness. The other thing too, and this is more important for therapists, is to obviously check in with survivors and
Mhm.
then, not asking them questions, but rather saying statements like, I'm thinking of you, right?
Mhm.
Oftentimes they don't want to answer questions. So just saying kind, compassionate, warm statements.
Mhm.
Um, this is something that's really a totally different piece, but I feel like it's so important to address is for many people, and this is going to be shocking, the first time they will actually know that they are a survivor is during pregnancy, labor, and delivery.
Mhm.
I once got a call from somebody who had 4 healthy living children. At her 5th pregnancy, she suddenly started to have flashbacks and memories,
Mm.
and she was so confused what happened, right? So there's a whole other layer of shock of what
Right.
happened to me. I had no idea this happened to me.
Right. Yeah.
So this may be the first time that this is something that's actually coming up for them.
Yes. Yes. Yeah, I mean, this is so, um, I mean, from the therapist side, because right, we're thinking as therapists about all of these connections and possibilities and things that somebody might be experiencing, and everybody's constellation of what they're experiencing is slightly different. Some similarities for sure. But the person who's experiencing it can't necessarily be aware of all of that. Um, we as therapists are trying to hold space that all of these things are possible and that we're going to be there to support whatever process they need to go through. But man, if you're just starting to piece the puzzle together yourself, that is just incredibly overwhelming.
Yeah.
While you're supposed to be like taking care of a baby.
Yeah.
Both of those things are so hard on their own, let alone
Yes.
to have to do them together.
And I think for me, as I reflect back on my journey, I think that really like what we would call traditional PMADs, I think for me really somewhat got resolved at about 8 weeks postpartum. But then for the remainder of that year, it was intolerable for me, not because of the PMADs itself, but because of the almost like aftermath of that
Right.
trauma.
Right.
Right? It was like
You
I
gotta
was
sort
hit
through
with,
all of it. Right.
yeah, it was like the first time in
Mhm.
my life that something that intense happened to me. It was the first time it was like, whoa. And,
Mhm.
what I will say is that it has led to beautiful healing. One
Yeah.
in which I will always tell my, again, support group members when they struggle with attachment with their infants, or bonding, I should say, I I will always tell them it took me about a year to fall in love with my baby, and
Mhm.
I'm in love with him today.
Mhm.
But it wasn't obviously his fault, but rather it was the traumatic response that I had that lasted for so long because unfortunately I wasn't getting the right care.
Mhm.
And my hope for all survivors is that they are seeing those, providers who are trauma informed, who
Yep.
are knowledgeable on the different nuances that come along with
Absolutely.
sexual abuse or any sort of abuse.
Mhm. Yeah, absolutely. Well, yeah, thank you. I mean, there are so many really important points that you brought in for survivors and therapists and professionals to think about, and it also sounds like this last part that you brought in about that is it's possible to feel better and that there is hope. That feels really, really important. So, thank you for everything you brought in today.
Absolutely. And thank you again for having me.